السلام عليكم ورحمة الله. هذه المحاضرة Clinical Biochemistry. Today's lecture will be on cardiac biomarkers and assessment of cardiovascular system. As to continue for the past lecture, which was about the lipid profile. As we know, the lipid profile carry the risk for the cardiovascular disease from increased cholesterol or increased LDL cholesterol, which lead to deposition of lipid in the form of macrophage loaded with these lipids, which was called bomb cells in the lining of the vessels, which led to narrowing and hardness of the wall of the arteries. This hardness and narrowing of the lumen can cause hypertension and decreased blood supply to organs and tissues, which eventually lead to increased risk of stroke or MI, myocardial infarction or stroke. Today's lecture will focus on the cardiovascular markers or biochemical markers used for assessment of cardiac injury or function. Cardiac injury or function. So, today's lab objectives, you should be able to know the definition of myocardial infarction, understand the current methods of calculating risk and their limitation and use of biochemical markers for the risk stratification of acute coronary syndromes, and to understand the markers of the congestive heart failure and their biological and technical limitation, understand the utility of inflammatory markers in the evaluation of the cardiac risk, and also you should know.
عفوا دكتور.
نعم.
آسف على المقاطعة، بس اكو طلاب ما يقدرون يدخلون. اعتقد اكو مشكلة بالرابط، فيقولون يا ريت انه يرجع يدز لنا اياه بالكلاس، لان ما يشتغل عندهم هذا الرابط القديم.
الرابط انا فتحت رابط واحد بس.
دكتور يا ريت لو تحاول لنا اياه بالكلاس من جديد حتى الطلاب يقدرون يدخلون، يعني ما يعرفون اياهم عندهم.
هذا صح. بس. هو موجود الرابط بالكلاس. Okay. So this was about the objectives. To define the myocardial infarction or acute coronary syndromes, which is a continuum of spectrum of disorders or diseases, all called acute coronary syndromes. Start from unstable angina to stable angina, myocardial ischemia ranging from the angina, reversible tissue injury, to unstable angina, which frequently associated with myocardial damage, to frank myocardial infarction and extensive tissue necrosis. If we can see this picture or image, The continuum of acute coronary syndromes range from the stable angina, unstable angina, non-Q wave MI, and Q wave MI. So this line go from the little or low risk to high risk or damage to the heart muscle. The stable angina is considered irreversible, while if we continue rising the risk, we will see to become irreversible damage to the cardiac tissue. And from the left to right, there will be increasing the risk. So what is the role of the biochemistry in evaluation and finding the diagnosis or stratification of the risk? Biochemical markers of the myocardial necrosis. Myocardial necrosis is accompanied by the release of the structural protein and or their intracellular macromolecules into the cardiac interstitium as a consequence of compromised or integrity of the cellular membrane. So if there is an ischemia, there will be injury to the cell membrane and the release of these macromolecules, proteins, or enzymes into the serum. And what we do, we measure these proteins or enzymes in the serum, which reflect the damage occurring in these cells, and also reflect the extent of this damage, presence and extent of the damage to the cardiac cells. Acute coronary syndrome. The diagnosis of the acute coronary syndromes by the WHO relies on three criteria. First is the clinical picture. Second is the electrocardiogram changes. And third, it is a chemical or biochemical investigation. Depending on the electrocardiogram, acute coronary syndrome divided into two categories, which is STEMI, that is to say ST elevated myocardial infarction, ST seen in the electrocardiogram, ST segment, ST elevated myocardial infarction, and non-ST elevated acute coronary syndrome. ST elevated myocardial infarction confirmed by the biomarker of necrosis, biochemical markers, while non-STEMI is further investigated by the biomarkers of the necrosis into unstable angina and non-ST elevated myocardial infarction. So this picture shows you the importance of the biochemical or biomarkers for diagnosis of acute coronary syndromes. But I have to emphasize here that the diagnosis of the myocardial infarction decision is on clinical picture. The last or final diagnosis of the myocardial infarction depend on clinical presentation. So what about the ST elevation? This is the normal ECG gram. We can see the waves of the ECG, normal ECG. Start with the P wave, QRS complex, followed by the ST segment. After the S, this is the S and the T wave. So the distance or voltage from the S wave to the T wave called ST segment. And when we observed in the myocardial injury, ECG change will start by the ST elevation. We can see here the ST elevated from the comparison to the normal. If this ST elevation is absent, it's called non-ST elevated myocardial infarction. If the ST elevation present, it's called ST elevated myocardial infarction. Okay, this is all about the ECG. We come now to the later on to the biochemical markers used in clinical cardiology. This is a summary of what we measure in the to assess the cardiac or clinical cardiology in the laboratory. First, we used to measure the enzymes, which are all non-specific, but it help in figuring out the site of the damage. We used aspartate aminotransferase, and another name is aminotransferases. Aspartate aminotransferase transfer amino group from the aspartate to alpha ketoglutarate. The old name طبعا الاختصار مالته AST. The old name is serum GOT. Okay. Second marker is lactate dehydrogenase, and it is isoenzymes. This marker is now obsolete, but it had been used for assessment of clinical cardiology in the past. These have discontinued measurement of the lactate dehydrogenase because it is very non-specific. It is non-specific. It's present in many tissues. Third marker is the creatine kinase, and it is isoenzymes MB, which is most specific. It is a specific marker for the heart, the isoenzyme MB. Myoglobin, cardiac troponins, both are proteins released by the cardiac injury. Sixth, the C-reactive protein, which is an inflammatory markers, or acute phase reactant proteins, which are elevated in the presence of inflammation, non-specifically. Seventh, and lastly, the cardiac natriuretic peptides. We come to all of these one by one. Aspartate is present in the many tissue, including red blood cells, muscle, liver, and heart muscle. So it's considered non-specific. It is used now for assessment of the liver function more than in the assessment of clinical cardiology. Come to the myoglobin. Myoglobin is the most sensitive marker for assessing the heart integrity. Myoglobin is sensitive, but it lacks the specificity. Each marker has its advantage and disadvantage. We come across each one. The myoglobin is highly sensitive and used as a negative predictive value, or it is negative predictive value. So what is meaning by the negative predictive value? If one comes with the chest pain and you measure the myoglobin, if the myoglobin is absent, you can rule out presence of the myocardial infarction. So its power is in its sensitivity and negative predictive value. Useful for early detection of the myocardial infarction and reperfusion. Myoglobin testing is more sensitive than creatine kinase and kinase, and it is isoenzymes, also more sensitive than troponin. It began to rise within few hours of the heart attack. Duration of stay 1 minute. it start to rise few hours after myocardial infarction and stay for at least 1 day, 12 to 24 hours. It is non-specific, although it is sensitive, but it is non-specific and may rise with any muscle injury or renal insufficiency. Rapid clearance after necrosis, as we see, it lasts for 1 day only. Sometimes its absence is used to rule out of myocardial infarction due to its negative predictive value. We come now to the second or another gold standard marker for the diagnosis of the myocardial infarction, which is an enzyme called creatine kinase. Creatine kinase present in cardiac muscle and skeletal muscles, but it is absent in smooth muscle. Creatine kinase, it has many isoenzymes, 3 isoenzymes composed of M and B subunits, which is further divided into the 3 isoenzymes called MM, BB, and MB isoenzymes. The CKMM isoenzymes is found predominantly in the skeletal muscle, while the BB isomer found in the brain. What we concerned for the heart function or cardiac function is the isoenzyme MB, which is specific for the heart. So CKMB. CKMB is the specific for the heart. So, what the fraction of the serum total CK carrying all the function of these isoenzymes? Let's see. The myocardial CK activity consists of 80% to 85% of CKMM, but we don't depend on the CKMM because it is non-specific. The cardial or myocardial CK activity composed of 80% of the CKMM and only 15 to 20% of CKMB. Although it is little fraction of the CK present in the heart, but it is used for this specificity. Wow. Non-cardiac tissues that contain large amounts of the CK have either CKMM or CKBB. So the MB isomer or function is either absent or present only in trace amounts in tissue other than the myocardium. So it is considered very specific to the heart, the MB fraction, so that it is used for evaluation of the heart integrity. After an myocardial infarction, the CKMB fraction accounts for only about 5% or more of the total CK. Little of the total, but it is used for the specificity. Myocardial damage appears to correlate with the amount of the CKMB released into the serum. So, the higher the amount of the CKMB, the more extensive the myocardial injury. So, this enzyme used not only to diagnose presence of the injury, but also it's used to evaluate the extent of the myocardial injury. Another term used with the CKMB is the CKMB mass, CKMB mass assay. Mass assay, it is more specific because it measures both total and CKMB isomers. CKMB mass, it has more specificity, ability to detect reinfarction, large clinical experience. Previously it is considered as a gold standard for myocardial necrosis. Now it is the troponin T cardiac troponin T. Okay. The CK mass measured by the percentage of the CKMB fraction to the total. We measure it as the ratio. We measure the CKMB and divide it by the total CK activity. Okay, and multiply by 100. It will show you the CK mass. We come now to the another marker, which is cardiac troponin T, which is the most specific marker of all. Cardiac troponin T, another protein similar to the cardiac troponin T as fraction is called cardiac troponin I, which is inhibitory one, and cardiac troponin C. But C is not used for the evaluation of the heart. Only troponin T and I used for this purpose. Cardiac specificity is considered 4+, 2 for the risk stratification. So if the value is correlate well of the cardiac troponin T correlate well with the outcome or prognostic or stratification of the risk for these patients. It remain elevated for a relatively long period, up to 2 weeks, but it is not as early as the CK or myoglobin. It starts to rise late on. Okay. This is the microfilaments of the cardiac muscle fibers consisting of the actin filament and tropomyosin. In the relaxed form and in contraction, the troponin act help contraction of the cardiac muscle. It consists of fractions I, C, T. The T and I fractions used to evaluate the cardiac function, while the C cannot be used because it is non-specific. This protein present in this filament help binding calcium and linking or joining or helping keeping the contraction of the heart muscle by binding the tropomyosin with the actin filament. In the relaxed state, the actin and tropomyosin are not bound firmly, so the troponin function is to aid in the contraction of the heart muscle. So if the heart muscle is going to be injured, it will be released into the circulation. All of this fraction, but we measure the I fraction and the T fraction only. Before we come to the inflammatory markers, we have to see the graph representing the time course of the elevation and staying of different markers. This is time 0 hours after chest pain. From here we start the chest pain onset, and the numbers above represent the hours after the onset of the pain. The first, which will rise rapidly, is the myoglobin, but it will disappear after 24 hours. followed by the CKMB and troponin, CKMB and troponin, CKMB disappear after 24 or after 48 hours or 72 hours. What will remain? What will remain is the troponins, troponin I and troponin T. It remain for uh, 2 weeks. This picture also shows you the normal ST segment with ST segment elevation and non-ST or ST depression in the non-ST elevated myocardial infarction. Or we can see the T wave inversion in the non-ST elevated myocardial infarction. Both BC figures represent myocardial infarction, but subgroups into according to the ST elevation or not. Okay. This was about the markers of the ischemia or injury to the myocardial infarction or myocardial muscle. We come now to the inflammatory marker or inflammatory biochemical markers concerned for the assessment of the cardiac function. We have the C-reactive protein and serum amyloid A. Both are rapid and acute phase reactant increased after inflammatory onset. Now we use high sensitive C-reactive protein instead of the C-reactive protein. High sensitive C-reactive protein. Both C-reactive protein and serum amyloid are acute phase proteins and help in assessment of cardiac inflammation, indicating plaque disruption and be prognostic in the unstable angina patient, which stay in the serum for the up to 3 days. If chest pain present with the elevated these markers, it carry advantage or it help in assessing the prognosis or prognostic state of the patients. If these both are elevated together in an unstable angina, this indicates presence of the ruptured plaque of atherosclerotic plaques. We come now to the markers of the myocardial or congestive heart failure or myocardial function. We use cardiac natriuretic peptides. Cardiac natriuretic peptides are peptides released by the ventricles in response to distension or fluid overload, and seen in many conditions like congestive heart failure and others. Plasma concentration of these peptides are increased in disease characterized by expanded fluid volume or induced by presence strain on the heart muscle, from the fluid overload. It can be elevated in the renal failure due to fluid retention, primary aldosteronism like Conn's syndrome, primary aldosteronism or primary hyperaldosteronism, congestive heart failure, ventricular hypertrophy or strain, thyroid disease, excessive circulating glucocorticoids, or hypoxia. All these conditions causes the increased release of natriuretic peptide. Natriuretic peptide function as natural diuretics. In this condition, in renal failure or congestive heart failure, the patient will be prescribed diuretics to get rid of excess volume. What the body do, it release natural diuretics. This cardiac natriuretic peptide will function to increase uh, excretion or excretion of water from the body by the kidneys. So it acts to decrease the fluid. Natriuretic peptides, I call it peptides because we have many, or I have at least 2 or 3 type of them. Natriuretic peptides are quantitative markers for hemodynamic cardiac stress and heart failure. I mean by the heart failure, it is inability of the heart to do its normal function as a pump. When heart fail, the pump function will be not enough to pump enough blood to tissue, so the fluid or the blood will have more hydrostatic pressure before the failing half of the heart. We have right-sided failure and left-sided failure. Okay. When the heart failed to pump the blood coming to it, the blood pressure or fluid overload will elevate before the receiving chamber of the heart. So it will present with fluid retention either in the systemic circulation or in the lungs, according to the side of the failing heart. Natriuretic peptides are quantitative markers of the hemodynamic cardiac stress and heart failure. Therefore, natriuretic peptides are the best markers to assess patients with the suspected acute heart failure. Natriuretic peptides help in the early diagnosis of the heart failure and also can quantify the disease severity. We have numbers or values. If it is less than that value or 200, okay, الأرقام مطلوبة. But we have ranges of the natriuretic peptide. First range indicates mild heart failure. Second range indicate moderate heart failure. Or the first one compensated, the second one moderate, and third range will represent advanced heart failure. So we will depend quantitatively on this marker to stratify the severity of the heart failure. Among the natriuretic peptides assays is B-type natriuretic peptide. It is written as BMP, B-type natriuretic peptide. Anti-pro-B natriuretic peptide, it is N-terminal, and mid-regional pro-A and B are clinically available. Okay, this was for the heart function as heart failure assessment. We come now to the few points about the hypertension. If patient present with the hypertension, what we do to investigate the hypertensive patients. The hypertension is a disease characterized by the elevated blood pressure. It is either primary, idiopathic, or secondary. And secondary, it has many causes, like a drug or another cause. One of the important causes of secondary hypertension is elevated aldosterone. Aldosterone from the adrenal cortex. It is an hormone regulating the blood pressure. Aldosterone secreted from the upper layer of the adrenal cortex. Its function, aldosterone function is to reabsorb sodium from the renal tubules and excrete potassium and hydrogen ions. So when an aldosterone elevated, there will be increased sodium retention and increased loss of the potassium and hydrogen ions into urine. This will result in the hypertension due to retention of sodium and water from the renal tubules to the blood, and also will result in hypokalemia and alkalosis. Hyperkalemia, increased potassium, and alkalosis, it is increased pH of the blood, together with the hypertension. So, what is the causes of the elevated aldosterone? Aldosterone can be elevated either primary or secondary hyperaldosteronism. The primary is an adenoma or abnormal growth in the adrenal upper cortex, which lead to increased secretion of the aldosterone, uncontrolled secretion of the aldosterone. Okay, it is seen in the primary as Conn's syndrome, adenoma of the adrenal cortex, Conn's syndrome, okay, or secondary to another disease like renal artery stenosis, because aldosterone is released in response to angiotensin 2. The angiotensin 2 also is come from angiotensin 1, and the angiotensin 1 increased by the action of the renin. So this system called RAS, renin angiotensin aldosterone. Okay, renin is released by the kidney in response to the osmotic pressure or hydrostatic pressure by the tubule, renal glomerular, or in the kidney. In response to the pressure, renin will be released. The renin will activate or will cause a release of the angiotensin 1. The angiotensin 1 will be converted into the angiotensin 2 by angiotensin converting enzyme. The angiotensin 2 act on the adrenal cortex to release aldosterone. So this is the normal mechanisms for controlling blood pressure. If we have renal tubular or renal artery stenosis, this will lead to an elevated pressure or decreased blood pressure in the kidney due to stenosis of its artery. Okay, decreased pressure reaching to the kidney will sensed by the renin, and renin will be elevated regardless the whole blood pressure, and this will lead to increased aldosterone. Okay, so what we'll do for the hypertensive like this, we will measure renin activity, plasma renin activity, if it is elevated, and we do measure the osmolarity of the urine and osmolarity of the blood, will help the diagnosis of the aldosterone. We can also measure the aldosterone level and cortisol to distinguish primary from the secondary hyperaldosteronism. This was what regard us with the hypertensive investigation. I think this will be enough for you for the knowing the different markers for assessing the heart and cardiovascular. I hope you to covered all the objective of the today's lecture. The rest, what will remain, will be covered, inshallah, in the practical session. We come to cases and scenarios of how to get benefit from the investigation of the markers related to the myocardial function and necrosis. This will conclude our lecture. If you have any question, please, I am glad to answer your questions.